absolutely loved biology in high school. So I am so excited to bring body systems to you today. This is a part of Module 3 for the NACC exam. A lot of you have asked about this module, and I understand it is definitely one of the most difficult ones to learn. So we are going to divide this into two parts. Today is part 1, so I hope you stay tuned. So hey guys, thank you so much for all your feedback. Welcome back to PSW exam preparation, or all things PSW with Winnie. So we are gonna get started, and let me know other modules that you want. I have heard that you also want module 11, so we can definitely cover that as well. And as always, please be sure to like, subscribe, and share these videos with your colleagues, please, because I'm hoping that they are actually helping a lot of students out there. So without further ado, we can definitely get started on Module 3. So as you know, there are some chapters that you need to go over in order for you to pass the exam. So the chapters are outlined over here. I'm just going to quickly summarize them. It's chapter 22, chapter 24, 30, 32, 33, and 43. In this video, we're only going to cover 4 chapters, which is 22, 24, 30, and 43. So always please just stay tuned for the next chapters. So the first thing that we're going to talk about is chapter 22. So what is chapter 22? This is skincare and prevention of wounds. So the main thing that you need to know about the skin is that it's the largest organ of the body. And a lot of things happen with the skin, guys, if there's something wrong with you. I'm talking about if you have maybe a health condition, it sometimes will show in your skin more than anything. So what is the skin? It's what we call the integumentary system. So if they talk about the integumentary system, they're talking about the skin. So a wound is any break in the skin. This predisposes a patient to infection. Just think about it. If you get a wound, maybe you fell. If maybe some dust gets into it, already you'll feel more pain, right? So it's the same thing. So why is this important for a PSW? Because we want to ensure that we do not cause any wounds, or if there are any wounds, that we do not prevent any further progression, or in all actuality, guys, we just need to understand that wounds are very expensive to treat. So there are many different types of wounds. You can have contusions, you can have incisions, you can have abrasions, you can have penetrating wounds, you can have puncture wounds, and you can have skin tears. And I know you're saying, whoa, Winnie, slow down. We are going to discuss these very, very quickly. But I just want you to know that there are many different types of wounds. We're also in this video going to discuss what pressure ulcers are, because this is another question that they want to ask you, because as the PSW, you're probably the first person to see a pressure ulcer, and it's important to you to observe and report to your nurse. So let's get started with the definitions. What is a contusion? So I always think of a contusion as a blow to the body. This is, for example, a bruise. So I always think of victims of domestic violence where maybe, they get punched or they get hit and then they say, oh, I fell down the stairs, that type of thing. That is a type of contusion because they have a bruise which actually shows, right? So any blow to the body is a contusion. An incision, however, is a surgical cut made into the skin. Think of someone who is having a C-section. They open up that abdominal area or abdominal wall to ensure that the baby comes out. So an intentional incision is one that's done during surgery. A puncture wound is like a stab or stepping on a nail. These might not cause a lot of bleeding, but they're often very deep and can be dangerous because of the risk of infection. So they're also known as closed wounds. A skin tear is typically seen in older adults. Why? Because their skin is so fragile. So a skin tear is when the skin fully or partly rips away from the body. They're more likely to happen to people with dry, thin, and weak skin. So, for example, you're helping Mr. Jones and you're just having a very tough shift and you're going too quickly and you pull him too tight because you're in a hurry. Before you know it, he could have a skin tear. Or maybe you wearing a ring and then the ring just goes on Mr. Lee's body. Now he has a skin tear. Or maybe you and your partner are just doing something too quickly and now you're repositioning someone without caution and you do it too quickly. That can also cause a skin tear. So the summary of this situation here is this. A skin tear is typically for people with dry, thin, or weak skin. A contusion is a blow to the body which causes bruising. An incision is typically intentional where it's done during surgery. And a puncture wound is like a stab wound or when you step on a nail. They may not be bleeding, but it could be deep. Okay, so that's the summary of the wounds that you should know in your scope. The next very important topic we're going to talk about are pressure ulcers. So it's very important for you, like I said before, to know pressure ulcers because you are typically the first one to observe them, particularly when you're providing care. Pressure ulcers are known as many different names, and you need to know these names. So what are the other names? It could be a pressure sore, decubitus ulcer, or bed sore. So there are 4 stages of pressure ulcers. So let's go through them right now. The first stage is when the skin is intact, but you can see some redness. So I put the word non-blanchable. Let me explain what that means. That means if you press on it, it doesn't change color. It will remain red. At this point, this is when you need to go and inform the nurse that, wait a minute, something is happening with Mr. Camuto because he has redness on his sacral area. Because if you don't report stage 1, guys, it will spread to stage 4 very quickly. And I will let you know that stage 4 costs a lot of money. This is why they ask you these questions in the exam, because they want to make sure that within your scope, you're able to report this in a timely manner. What is stage 2? This is partial thickness or the loss of the top skin layer. If you remember before, we went through the layers of the skin, or we're going to go into more detail actually in the next part, but there's the epidermis, the dermis, the hypodermis, the subcutaneous layer, all these different things. If you want to take a look at the diagram, that will be very helpful. But in stage 2, it's the partial thickness or loss of that top layer. Stage 3 is a little bit deeper than stage 2. This is where maybe you now see the fat, and this is full thickness tissue loss. So you can actually see the fatty layer. Stage 4 is the highest one, where now you can see every part, and this includes the bone, the muscle, and the tendons. I will let you know that wounds are very painful. Before someone gets their dressings or before the nurse gives the wound care, where you assist, by the way, we typically pre-medicate a patient because it's so painful. Can you imagine having a wound that is so deep in stage 4 where your bone and your muscle are exposed? That is a high level of pain. So why is this important? It's important to know because you want to stop this at stage 1 before you have somebody who is now in a high level of pain, where now you have to get the highest wound supplies, where now you have to get the highest level of care at stage 4. Again, it is very costly. So ensure you always report any change to the nurse. So what's the key to prevent a pressure ulcer or a pressure sore or a decubitus ulcer? Repositioning. And always, if they ask, how often do you reposition? You should say every 2 hours. Also check for moisture. What does that mean? Make sure someone's not wet. If they're incontinent, make sure you change them every 2 hours. They could be incontinent of bowel, they could be incontinent of urine, but make sure you change them every 2 hours. And also, when you are repositioning, watch for friction and shear, which we have covered in other videos as well. So the next thing that you need to know are that pressure ulcers are usually over a bony prominence. What does that mean, right? So it means that the bone is pretty much jutting against the skin, and that pressure will cause an opening or will cause what we call a pressure ulcer. So these are pressure points. There are many different types of pressure points. For example, the sacrum, it's got that. It's a bony prominence. The heels, the elbows, the hip, the shoulder, the ear, the knees, the cheeks, the toes. These are all over bony prominences, right? So at the end of the day, prevention is better than healing because healing is very, very expensive. So there are a lot of specialized equipment, which again are expensive. Sometimes the family will have to rent it out, which is very expensive per month, which goes back to the point of prevention is better than healing, right? But the specialized equipment is there, but there is also sometimes not enough. So we want to try and prevent this so that someone doesn't have all these disruptions and issues and complex health conditions. But sometimes you can see the beds, you can have different footwear, and you can also have what we call heel elevators, and they elevate the heel so that that bony prominence in the heel is not touching against the bed and causing a pressure sore. So the next part is gangrene, and we've spoken about gangrene multiple times, but I do like to talk about it often because I just want to really hone it in so that you are very aware of what it is. This is the death of tissue. So when your tissue dies, it dies, guys. Like if you think about somebody who unfortunately passes away, there's no restoration of life, unfortunately. It's the same thing with gangrene. Once the tissue's gone, it's gone. So gangrene typically is the prerequisite to amputation. And as we know, amputation is when you remove a body part. And we spoke about phantom limb pain with this. We spoke about prosthesis with this. If you're not sure about what I'm talking about, it's in other videos. So hopefully you are going over the videos in some sort of order in order for you to understand what these terms really mean. So phantom limb pain, to summarize it quickly, is just pain that you feel in an area that doesn't exist. So now we talk about edema. So someone has got edema or they're edematous. This is when there's excess fluid trapped in the body tissues. So although it can affect any part of the body, it's typically seen in hands, arms, feet, ankles, and legs. So I would say feet and legs the most, but it could be in hands as well. But you just see that swelling because that fluid is trapped. It has nowhere else to go, so you start to kind of be puffy, right? So it could be due to medication, pregnancy, or an underlying disease such as CHF or kidney disease. So edema is something where you, in your scope, would put on the compression stockings, for example, to make sure that the, blood flow, but just that the fluid, blood flow, is actually moving. For example, with the veins, you want to make sure that the blood flow is going back to the heart because this could be a cause for edema. So always make sure you understand that in your scope, putting on compression stockings in the morning and taking them off at night is very, very important. Arterial ulcers. So these are open ulcers at the lower legs. So let's just go through this anatomy just a little bit. We are going to cover it in deeper detail in part 2. But what are arterial ulcers? So I always think of the artery A for A, which means artery going away from the heart. A for A. So we are talking about something that goes wrong when blood that's going away from the heart has some sort of interruption. Something happens. Something went wrong. So we have to investigate this a little bit further. So because we know A is for A, something going away from the heart has some sort of disruption, so there's poor arterial blood flow. This poor perfusion causes issues because, like we know, the artery goes with oxygen, okay? So we are supposed to have oxygenated blood that flows away from the heart, okay? But something goes wrong. So once you have the ulcer, it means there's something that is causing an issue where the oxygen is not reaching the lower legs. So what happens? The body has to fight it somehow, right? Because this is a pathophysiology of the whole arterial blood system. So what happens is that a wound will develop because there's a very big oxygen deprivation that's going on. So the wound develops because the body doesn't know how to actually deal with this issue. So that's when you end up with an arterial ulcer. Now to go further, if you remember from videos before, but again, we will cover this in part 2, we have what we call veins. If arteries go away from the heart, veins go toward the heart. So now with a venous ulcer, where venous comes from the word vein, there is an issue with something or the blood that's going toward the heart. So now because there's an issue there, the body doesn't know what to do, another pathophysiology, so leg ulcers are formed because there's an issue with circulation in the veins. So now these are very difficult to heal. And sometimes it's so bad to a point where they may weep fluid. What does weep fluid mean? It just means you'll see fluid literally oozing out of the legs. And then, of course, you can see pitting edema, which we said edema is a collection or excess fluid in the body tissue. But pitting means if I put my finger in that area, it'll take a long time for the skin to rise back up. It forms a pit. That is what happens typically with venous ulcers. So again, like I said, this is where you as a PSW would put on the compression stockings, or a nurse could come and put on elastic bandages. Because of the weeping and because of the openings and because these are ulcers, they're high risks of infection. Okay. So I hope you guys are still with me. I know this is a lot of information, and I'm thinking I might even divide this video into 3 parts because it's a lot, but I just want to make sure that you do really understand the material that we're covering. So the next thing that we're going to talk about is wound healing. It has 3 phases. So when I was in school, I always tried to remember, mnemonics or acronyms. I don't really know what the right word is. But for example, when I was learning wound healing, I would say IPM just to remember the order. So in this case, I means inflammatory, P means proliferative, and M means maturation. So I know these are really big words, but I will try to explain what they mean to really break it down so that it's easier to understand. So we've spoken about the wounds, right? The wounds are there. So let's pretend you fell off your bike, and now you're going to need to heal. The first phase after you fall off your bike is the inflammatory phase. What does inflammatory mean, or what does it come from? That's inflammation. So every time you have inflammation, there's a lot that happens to your body. This is where you see warmth. This is where you see redness. This is where you see loss of function, right? So eventually the bleeding will stop after you fall off the bike, but you start to hold it and it's hot. And you're like, oh my goodness. Then you know that something happened. After this phase, maybe day 3, you start to go into the proliferative phase. What does to proliferate mean? I know it's a big word, but in a nutshell, it means to heal. So now the body has gone through the warmth, it's gone through the redness, it's gone through the swelling. But now what needs to happen is it needs to heal. This happens around day 3 to day 21. And then after this phase, we go through what we call the maturation phase. This is when now it's mature. So first you have this whole explosive part where it's hot, it's warm, it's swollen. And then after that, you start to heal. And at the end, it's mature. Now the scar will form and eventually gain strength, and you can get like a nice new layer of skin after some time. So IPM stands for inflammation, proliferation, and maturation. Okay, so that's to do with wounds. So now we're going to go a little bit deeper and we're going to talk about hemorrhaging. So what is hemorrhaging? So hemorrhaging is when you lose a lot of blood in a short period of time. So ideally, you want the blood to just stay in your body, guys. We've spoken about how, the artery is away from the heart, the vein is towards, but you kind of want that circulatory process to just be perfect, right? But let's say something happens. Let's say there's that whole unintentional injury, such as a stabbing. What happens in that moment? So this is when you lose a lot of blood, and you don't want to lose a lot of blood, but it happens. As the more blood you lose, it may lead to shock. So what is shock? Shock means there's not enough blood supply to your organs or tissues. The purpose of the circulatory system is to supply blood to every single part of your body organ, every single part of your body tissue. If that blood is no longer there, there's no oxygen-rich blood, and slowly organs start to shut down. That will lead to death. So this is a medical emergency. And the signs and symptoms are very clear. If you no longer have blood circulating because it's coming out of the body, the blood pressure will fall. The pulse will get weaker. But it starts to get rapid because that's the homeostasis, because it's saying something is wrong. I'm getting weaker. Something is wrong. I'm not having enough blood circulation. Let me go faster to ensure that there's blood to these organs that are not getting it right now. So the body always tries to compensate when there is a pathophysiology. The breathing rate increases because the body's thinking the more oxygen that I put in, the more oxygen I can get to these organs that are deprived. Now the person is restless because before death, guys, and we're going to talk about this when we cover the palliative module, but before death, there's a lot of restlessness because a person can feel something's wrong. Something is not going well with my body. Something is not going well with me. What do I do? And then, of course, confusion because there's no circulation to the brain, right? So shock and hemorrhage are medical emergencies. Okay, so now we're going to go further and we're going to talk about the types of wound drainage. So there are many different types, and do you need to know these? Unfortunately, you do. Just so you are aware when you are helping a nurse or just in terms of observation, guys, just so you can report this in a good way to a nurse. Okay, so in terms of wound drainage, there are 4 types of wound drainage that you must know about. And these, again, are covered in the chapter that we are going over. So the first one is serous. So serous derives from the word sera. So a lot of this medical terminology, guys, always has something where it's derived from. If you are very interested to learn better, it's important to know these terms. But serous is clear and watery. So that's the easiest one to learn. The next word is sanguineous. Sanguineous means bloody, okay? So if you now have serous, which we said is clear and watery, and sanguineous, which is bloody, if we combine the two, we get serosanguineous. So that means you have that thin and watery drainage that we mentioned for sera, but you also have a blood tinge from the sanguineous because we've combined the two if you look at it. So serosanguineous drainage is thin and watery drainage that is blood tinged. And the final one, which means maybe there's an infection or there is an infection actually, is the purulent one. This is thick. It typically has a foul odor, but it could be green, it could be yellow, it could be brown, but it's very strong smelling. So because it's something to do with an infection, probably you will typically get antibiotics when you have purulent drainage. Okay. So that was chapter 22. I'm hoping that I'm not confusing you too much. There is a lot of information, but I'm hoping that that was a quick, good summary for you to study chapter 22. The next chapter we're going to go over is chapter 24. I will just kind of summarize this very quickly. This is measuring height, weight, and vital signs. So we've already covered this one in 10 random questions you cannot get wrong in the NACC exam. If you want to just scroll by the video, you'll see it. It covers all of them in depth. So the vital signs that you must, of course, know are blood pressure, temperature, pulse, and respiration. I have them all summarized in that video and how you should know the values. The values are outlined for you. But what I will say that I didn't mention in the last video is about measuring height and weight. When you measure height and weight, just ensure that the patient is wearing the same clothes, especially for weight, guys. If I measure my weight and I'm wearing jeans and a sweater, and then the next time I measure my weight and I'm not wearing anything, there's going to be a big difference, right? So always ensure that if a person wears a gown on Monday, that the next weight on Tuesday will always be in a gown, and specify when you record that patient was wearing gown only, that type of thing, just so you know. Also measure at the same time per day. There's no point in measuring someone at 8 a.m. and then measuring them at 12 p.m. because at 12 p.m. they've had a lot of fluids, breakfast, everything under the sun, maybe a snack, I don't know. But at that point, they're going to weigh more. So typically we measure someone first thing in the morning after they void. And voiding means they went to the toilet, they went to the bathroom, they urinated. If they had a bowel movement, they did that. And then you weigh them right after that with the same clothes that they had the previous day. This is the biggest indicator to see what someone's weight is, especially for someone with congestive heart failure, guys. You really want to ensure that there's enough output. So you want to ensure the weight is accurate. So always, always ensure that the person wears the same clothes daily. So that's chapter 24 summarized. The next chapter is chapter 30. So chapter 30 talks about bowel elimination. So bowel elimination is covered in another module as well, but it's a very, very important chapter. So as you know, bowel elimination is a part of your excretory system. It's a physical need, okay? We need to go to the bathroom to have a poo. So what's bowel? Bowel is literally feces or pooing or number two, however way you want to look at it, but it's just a very important need of the body. So when we remember Maslow's hierarchy of needs, this particular elimination falls under the physiological level, which is the big base which you have to go through before you go to the next one, which is safety. So the first part is you need to have water, oxygen, and all that stuff, right? So bowel elimination is in that first level. So people have different frequency. I've seen people who go once a week. I've seen people who go once a day. I've seen people who go 3 times a day. Whatever your norm is your norm. The issue is when something changes from your norm. That's when we can see that there is a particular issue. So we always want to know what someone's baseline is in order for us to see if there's a change, and then the change should be reported to the nurse in a timely manner. So what does stool look like, or what does poo look like? It's brown, it's soft, and it's moist. So we have what we call a Bristol stool chart. And guys, this is the best way to really know what poo should look like and like the right shape. it illustrates what constipation looks like. It illustrates the pellets. It illustrates the nice curvy one, it illustrates the color, and then it illustrates what diarrhea looks like. So at the very part, you'll see, okay, this illustrates constipation. And as you go higher and higher, like number 3, it shows the nice poo. And as you keep going, you'll see diarrhea. So it's important to just look at the chart. You don't have to remember each part, but just look at it so that you know what exactly is it that we're looking at. So what is constipation? Constipation is when you pass fewer than 3 stools a week, or you have infrequent stools, or if it's lumpy or hard. So I didn't know about this until much later, but sometimes when you're in the washroom and you're really like groaning and it's difficult to pass, I just thought before nursing school that, okay, whatever, right? But later I found out that that is actually constipation. When you go for so long, you're in the toilet for so long, and then you notice, oh my gosh, when you look, it's just 2 little pellets and you're so upset. That's actually constipation, right? That strain is constipation. So, sometimes you also feel like, there's a blockage in your rectum and then it prevents bowel movements, or you feel as though you cannot completely empty it, right? So what do you do? This is all a part of constipation. What do? You do some dietary changes. Like your mama always said, drink water, drink water. You drink a lot of fluids. You get active, guys. Start moving around, right? And sometimes if you really need to, you'll take some medication to allow you to go to the bathroom. And if push comes to shove and worse comes to worse, you can provide an enema. And if you remember, enemas are usually given in Sims position in a facility, but if you're administering it yourself, you definitely probably won't do Sims. But just for you to know, if we're delivering an enema in a hospital setting or any other setting for that, it's in the Sims position, which is also the side lying position. And then, of course, the final one is fecal impaction. What is it? It's when your feces are impacted. So this means that there's a prolonged retention, or what this means, the summary is just that, guys, there's a buildup of feces, so they can't move. There's like a blockage, okay? So what nurses typically do is they just take their finger and they flick out that blockage. And as soon as they flick it out, a lot of poo typically just comes out, okay? So this is what they do to check for the impaction. You can feel like this stool and it's blocked. And as they do that, they can literally sometimes just take it out and then the poo will slowly come out. So this does happen a lot, especially in facilities where someone is immobile, like they're not moving around or anything. And then the poo becomes stuck in that area. Diarrhea, like I said, is the opposite of constipation. They're on 2 different levels. This is just the frequent passage of stool. This is where they go rapidly. There's nothing that's been absorbed, guys. It's just fast and it's coming, and diarrhea is urgent. Like, when you have diarrhea, you gotta go, you gotta go, you gotta go. So you don't really absorb the nutrients. So because of that, lots of water needed. Lots of electrolyte replacement is needed as well. Incontinence is different to these 2, and people get these confused. But to be incontinent means you have no control over your bowel or your bladder. With diarrhea, it doesn't necessarily mean you're incontinent if you have to go, because sometimes you're holding it in as much as possible, but eventually it wants to come out. That does not make you incontinent. That's diarrhea. However, with incontinence, you just cannot control it. In fecal incontinence, you cannot control the passage of your feces. They just come out. Because a lot of times you can maybe try and hold it in, but incontinence, you cannot. So what happens with someone with incontinence? You put them on toileting schedule. And if someone with fecal incontinence, you put them on bowel training as well. Flatulence is when you have excess gas in your stomach, and it can be very painful. So sometimes we typically say, take a walk, exercise. If this doesn't work, we might put a rectal tube, which relieves the pressure or relieves that gas, or even putting someone in the Sims position helps as well. And the enema that we already spoke about before is when we just put liquid in the rectum to allow the passage of stool. This is typically done with the nurse and the PSW. So what you do is you put someone and then you leave them on the side. And then what you do is you put the enema in and then you come back after 30 minutes. And believe me, there will be a very big bowel movement. So that in a nutshell is what an enema is. So now we're going to talk about an ostomy. Why would anyone need an ostomy? This could be because there's a certain type of condition or something going wrong in the large intestine or the small intestine that warrants someone to have an opening in the abdominal wall because they can no longer use the rectum like everybody else does. So this is a very, very difficult and challenging thing. Because of course, we all want to understand that having a bowel movement, guys, is a very private issue. So once you have an ostomy, it's as if the whole world knows that you had a bowel movement, which is very difficult and causes low self-esteem. But what is an ostomy? This is an opening, okay? So a colostomy just means an opening in the colon. So again, this is the opening between the colon and the abdominal wall. The ileostomy comes from ileo and stomy. So this is the opening between the ileum and abdominal wall. So take a look at the prefix and suffixes here, guys, to understand the location of the ostomy. The colostomy is in the colon. The ileostomy is in the ileum. The difference, however, is this. If you think about the location of the small intestine, which the ileum is a part of, it's the first part. By the time, like I would say, the things are going down and all the food you've eaten is going down, the first place it gets to is the small intestine. So there's not a lot of absorption of nutrients at this time. There's not a lot of absorption of water at this time. So the stools in the ileostomy are very liquid-like. However, in the colostomy, they're a little bit harder because they've kind of gone through the small intestine and then they started moving about. So always remember that for the ileostomy, because they're liquid-like, let's think about diarrhea, guys. It burns sometimes, it's hot, and that's the type of thing that happens with the ileostomy. So because of that skin irritation, good skin care is essential. So for these particular ostomies, the pouch is changed every 3 to 7 days, or if there's a leak, right? If there's a leak, of course, it needs to be changed. And this is changed by the nurse. You just inform them. And you also need to know that you can empty the pouch as well. It is in your scope to empty the pouch. Do not wait until the pouch is full. Wait until maybe it's about 3/4 full, or if you see flatus, which means gas, like it's bulging, because once it's bulging, it will probably explode. So ensure that you always check the ostomy. And the final thing in this particular section is that you can test stools for blood. So there are some types of blood that are very noticeable, and we call that melena, where the blood is the stool is black and tarry, right? So this is where you can see it once you have the bowel movement. And this is typically because you have internal bleeding up in your body, in your stomach, in your upper GI tract or upper gastrointestinal tract. But you also have sometimes blood that's hidden. So a lot of times as you get older, or if you have any issues or you have a family history, you might get a test kit where you have to kind of put your bowel movement on the test kit and then you send it over and they take a look at it under the microscope. If they see any blood, that is called occult blood. The word occult means hidden. So it's just literally saying you have hidden blood. All right, guys. So we're almost there. So this is now, the final one is chapter 43. caring for older adults. So I will not be covering it in this video, but I will let you know that we did cover it in the video NACC Module 1 summary. Just scroll to the very end of the video and you will see everything to do with chapter 43, where you really see the different changes, like the physical changes, the social changes, the changes in the integumentary system, the changes in the nervous system, the changes in the endocrine system, all the changes that happen to older adults. All right. So thank you so much for joining me for part 1. Like I said, I think we are going to break this down in 3 parts. It's a lot of information, but I'm hoping that this was helpful to you. Let me know what you think. So again, thank you so much, guys, for always coming back and, of course, your feedback. Please share this with your colleagues. It really goes a long way because we all want to make sure we pass the NACC exam. It's not easy. Or even if you're a student, pass this along if you're studying for your exam, right? Whatever college you're at, make sure you pass this video along. So I will see you in the next video, guys. Thank you so much and have a wonderful day. See you next time.